let's picture the scenario. It is 9 a.m. on a Tuesday. You've got your coffee. You open the door to exam room 3, and you have a patient sitting right across from you.
We all know the one.
Right. Maybe they're 45, maybe 50,
Mm-hmm.
and they're feeling good. I mean, no pain, no morning stiffness. They are bounding up the stairs,
Mm-hmm.
but they are worried.
Yeah.
Maybe they're out carrying a little extra weight, or, maybe they blew out an ACL playing college soccer 20 years ago. They know the clock is ticking on those joints.
Oh, absolutely. They can hear it ticking.
Exactly. So they look you dead in the eye and ask the million-dollar question. Can I exercise my way out of this? Like, if I start running or hitting the gym right now, today, can I stop my knees from going bad?
It's the classic proactive patient scenario. And honestly, for a clinician, it is one of the most deceptively difficult questions to answer in practice.
Because what they're really asking for is a guarantee.
Exactly. They
Oh.
want a guarantee. And our instinct, I mean, almost a knee-jerk reaction, pun fully intended, is to just say, yes, absolutely, go exercise.
Because we are completely programmed to believe that exercise is medicine.
We are. And we know for a fact that if you actually have osteoarthritis, exercise is the gold standard treatment. We prescribe it all day.
Right, so logically, my brain wants to say, well, if it treats the disease, it surely must prevent the disease, right? A plus B equals C.
Yeah, that is the assumption we all really want to make. It feels safe. It aligns perfectly with every public health message out there, motion is lotion.
Motion is lotion.
But we really have to hit the brakes hard right there. Because when you actually peel back the layers of the clinical data on this, the reality is a lot messier.
Messier how?
Well, here's the hard truth. While low-impact exercise is undeniably the best tool we have for managing established symptoms, there is virtually no direct evidence that it prevents symptoms from developing in the first place.
Wait, none.
Hmm.
That's a massive distinction that I think gets totally lost in the noise.
It gets completely lost.
We are conflating treatment with prophylaxis.
Precisely. We are conflating the two. And that conflation is actually quite dangerous. We have mountains of data showing that if your knee hurts, movement helps dampen that pain. It improves function.
Sure, yeah.
But for that asymptomatic patient sitting in your office, the one who feels totally fine right now, we cannot look them in the eye and promise that joining a gym or starting a walking program will stop OA in its tracks.
The evidence just isn't there to support a claim of prevention.
It really isn't, not for specific symptomatic prevention.
Which puts us in a really, really awkward position clinically. Because, I am certainly not going to tell a 45-year-old, don't bother exercising, it won't save your knees, just wait until they hurt and then come back and see me.
Right, no.
That feels entirely negligent.
It would be negligent, and frankly, it would just be terrible medicine.
Right.
But this is exactly where we have to be surgically precise with our language. Our mission isn't to discourage activity. It is to redefine the actual goal of that activity. We have to manage their expectations and draw a very bright line between prevention of a specific pathology and general health promotion.
So let's unpack that pivot, because I think this is the core of it. How do we reconcile the data, or I guess the lack of data, with the fundamental need to promote a healthy lifestyle?
Right.
If the data says no proven prevention, what is the actual conversation we're having in the clinic?
The conversation basically shifts from specific prophylaxis to a general health strategy.
Okay.
The default clinical posture should absolutely still be to recommend low-impact exercise. We are talking about swimming, cycling, walking activities that keep the joints moving without excessive repeated impact loading.
But the reasoning you give the patient changes.
Exactly. The reasoning shifts entirely. You aren't prescribing it as this magic shield against knee OA specifically. You are prescribing it because it promotes overall joint health, cardiovascular health, metabolic health, and mental well-being.
I see. So it's almost like a rebranding exercise in the clinic. You're telling them, hey, do this because it's great for your heart, your brain, and your muscles. And the knee health is sort of a hopeful side effect rather than the guaranteed primary target.
That is a great way to put it. You have to be transparent about the uncertainty. We simply cannot promise it stops the disease process in the cartilage. However, we can say with moderate confidence, and that is the specific term the guidelines stick to, moderate confidence, that this approach minimizes harm and maximizes general health.
It's the safe default.
It is the safe default. Think of it this way. If they do develop OA later on, a patient with strong quadriceps and good cardiovascular health is going to handle that diagnosis infinitely better than someone who is totally deconditioned.
Right. You are building up their physical reserves.
Mhm.
But let's dig into that moderate confidence part for a second. It sounds like we are acknowledging that while we don't have the smoking gun proof of absolute prevention, we are pretty darn sure this isn't going to hurt them.
That is the key right there.
Yeah.
We are operating on the fundamental principle of do no harm while maximizing the do good.
Yeah.
We know inactivity is harmful. That is a given. And we know high-impact loading on a vulnerable joint might be harmful. So the middle path, the low-impact activity, is the rational, safe harbor for these patients.
Okay, so that covers the average risk patient, the weekend warrior who's just getting a bit older. But let's be real, clinical practice is rarely just average.
Very true.
What about the patient who isn't just generally worried, but has significant, clearly identifiable risk factors? I am thinking specifically about the two big ones we see every day, obesity and a history of knee trauma.
Right.
If a patient has a BMI of 35, or they tore their meniscus 10 years ago, does that general health advice still hold up? Or is that just too passive?
That is exactly where we have to deviate from the standard script. If you identify an at-risk profile in the clinic, exercise alone is highly unlikely to be a sufficient preventative shield.
So the walking program isn't going to cut it.
No. You cannot just tell a patient with a BMI of 35 to go for a walk and expect that to somehow neutralize their OA risk.
Let's drill down on the obesity factor first.
Yeah.
Because I feel like lose weight is probably the most generic, overused advice in all of medicine. But strictly biomechanically, why is exercise alone not enough there?
It comes down to the raw physics of the joint. We often forget the multiplier effect when we talk to patients.
The multiplier effect.
Right. When you walk, the load on your knee isn't just 1-to-1 with your body weight. It is roughly 4 times your body weight.
Wow.
4 times. So if a patient is carrying 50 extra pounds, that is 200 pounds of extra force grinding through that cartilage with every single step they take.
200 pounds.
Mhm.
That really puts it in perspective. So telling them to just walk more to save their knees.
Is literally like bringing a water pistol to a forest fire. The mechanical load is simply too high. For these specific patients, the data highlights the absolute priority of weight management. Specifically, we should be looking at a target of at least a 10% weight loss.
10%. That's the threshold.
That is the magic number where we actually start to see significant, meaningful unloading of the joint. Exercise helps the support structure, yes, but the weight loss actually reduces the daily mechanical trauma.
So the conversation there shifts to, we need to exercise for your heart, but we primarily need to change the math of the load on your knees.
Correct. The diet and the weight management become the primary knee-saving intervention, with the exercise acting as a necessary support system.
Okay, that makes sense. Now, what about the former athlete, the one who had the ACL repair in college? They aren't overweight, they are strong, they are active, but we know that knee is basically a ticking time bomb for post-traumatic OA. What do we tell them?
That requires a completely different toolbox. General walking or cycling doesn't fix the subtle instability from an old injury. For them, you need targeted injury prevention strategies.
So beyond just general fitness.
Way beyond. We are talking about neuromuscular training and proprioception work.
I feel like neuromuscular training is one of those clinical buzzwords we throw around a lot. What does that actually look like for the patient on a Tuesday morning? We aren't just talking about doing more leg extensions, right?
No, definitely not. Leg extensions just build the muscle bulk. Neuromuscular training is about teaching the nervous system where the knee actually is in space.
Huh?
It is all about dynamic stability.
So balance work.
Exactly. We are talking about single leg balance drills, using wobble boards, doing plyometrics that specifically focus on landing mechanics.
Right.
It is about waking up that feedback loop between the brain and the joint so that the muscles fire at the exact right millisecond to protect the cartilage during movement.
That makes a lot of sense.
Yeah,
It is like they need software updates, not just hardware upgrades.
that is a perfect way to put it. General health promotion isn't enough hardware for them. They need a software update to stabilize that vulnerable joint.
Now, let's talk about the tipping point. The moment the asymptomatic patient becomes a symptomatic patient, say they come back 6 months later and they say, okay, doc, now I have this nagging pain when I tackle the stairs, or my knee feels really stiff every morning.
That is the critical juncture. And honestly, it is where a lot of clinicians unfortunately miss the boat.
How so?
Because the moment symptoms occur, whether that's new pain, worsening pain, or functional limitations, the entire clinical strategy has to flip completely. We are no longer in the business of general health promotion. We are now firmly in the realm of treatment.
So the intensity changes. The actual exercise prescription changes.
Everything changes. The focus moves to intensified, tailored interventions aimed specifically at symptom management and improving function. This is where our evidence is actually the strongest. We know exercise works here.
Right, because now it's a proven treatment.
Exactly. So you shift from a somewhat passive stay active advice to a highly structured, perhaps physically supervised, rehabilitation plan.
It is interesting because to the patient, it might feel like a subtle shift. Just keep exercising. But clinically, on our end, it is a totally different protocol. You are moving from do what you like to stay healthy to do exactly this to treat your knee.
It is, and missing that shift is a very common error. You really don't want to treat a symptomatic patient with vague, prevented advice. They need actual treatment. If they have pain and you just say keep walking, you might be completely ignoring biomechanical issues that are actively causing that pain.
Speaking of errors, let's dig into the what not to do file for a minute. We touched on this at the beginning, but I really want to explicitly call out the clinical pitfalls. The biggest one seems to be that extrapolation error we mentioned earlier.
Oh, it is the most common logical trap in medicine. We naturally assume that the mechanism that heals is the exact same mechanism that protects.
Right.
But treatment trial evidence simply cannot be directly applied to primary prevention. Just because ibuprofen reduces a fever doesn't mean taking ibuprofen every day prevents you from catching the flu.
That is a brilliant analogy. It really highlights the flaw in the logic.
And with exercise, it is particularly risky because we tend to assume exercise is always benign, always good. But if we extrapolate incorrectly, we might prescribe high-impact or unsupervised exercise solely for the purpose of prevention. We might look at them and say, go run marathons to toughen up your knees.
Which could actually cause the very thing we're trying so hard to avoid, especially if they have those underlying risk factors we just talked about.
Precisely. High-impact loading on already vulnerable cartilage without a clear, proven benefit is just a recipe for harm. We have to be very careful about intensity. We can't just assume harder is better when it comes to joint preservation.
There is another technical point here that I found really fascinating regarding imaging. We love our X-rays in the clinic. We love our MRIs. But the consensus seems to be that we shouldn't use them as a surrogate marker for success here.
Please, whatever you do, do not treat the X-ray. This is absolutely crucial. You cannot use radiographic changes as a surrogate for symptomatic prevention.
Because the picture doesn't always match the patient.
And never consistently. We see
Yeah.
patients all the time with terrible-looking X-rays knees that look like an absolute war zone who have zero pain and great function. And conversely, we see patients with pristine, beautiful X-rays who are in absolute agony.
So if we focus all our energy on preventing the bone spur, we are basically chasing the wrong ghost.
Exactly. Our clinical goal is to prevent symptoms, pain and functional loss. We are treating the person sitting in front of us, not the picture on the screen.
Right.
If a patient is highly functional and pain-free, I really don't care what their X-ray looks like. If you tell a patient, oh, your X-ray looks slightly worse this year, you might actually scare them into inactivity, even if they feel totally fine.
Which is the definition of the nocebo effect.
It is the textbook definition. You are creating disease where there are no symptoms.
That brings us nicely back to the human element of all this. Patient communication and shared decision-making. Because ultimately, the patient is the one who has to go home and do the work. If we prescribe a rigorous swimming regimen and they absolutely hate the water, we aren't getting anywhere.
Compliance is everything. The objectively best exercise program in the world is completely useless if the patient won't actually do it.
Yeah.
If a patient only tolerates or simply prefers low-impact work like cycling, you support that choice. Even if you theoretically thought a slightly higher intensity might be beneficial for them, if they won't do it or if it hurts them to try, it is useless. You have to support the choice that ensures long-term adherence and safety.
What about the highly motivated patient, though? The one who comes in and says, I will do anything. I will run through a brick wall to save my knees.
You harness that motivation, absolutely, but you temper it with brutal honesty. You encourage the exercise, but you have to be the voice of reason in the room.
How do you phrase that without deflating them?
You say, this is fantastic for your heart, your muscles, your mood, and your general stability. But you must be transparent. You have to add the caveat. While this is great for your overall health, its specific ability to prevent knee pain down the road is uncertain.
It is really about building trust, isn't it? If they do end up getting OA 5 years later, they won't feel like you lied to them.
Exactly. You do not want them coming back to your clinic saying, you told me if I did squats every day, I wouldn't get arthritis.
Right.
You want them to know they did everything they possibly could for their general health, and now you are there to help them manage the next phase.
And that leads perfectly to the monitoring aspect.
Mm.
The advice we give isn't just set and forget it. You don't hand them a general health prescription and say, see you in 10 years.
No, active monitoring is the safety net for this entire strategy. You have to monitor for symptom onset.
Because of that tipping point we discussed.
Because the moment that pain starts, the plan has to change immediately. You need to catch that transition from asymptomatic to symptomatic as early as possible so you can switch gears directly into treatment.
It really emphasizes that this is an active, ongoing relationship, not a one-time prescription.
Absolutely, it is a partnership.
So let's bring this all together for everyone listening. We have covered the evidence gap, the pivot to general health, the specific risk factors, and the communication strategy. If we had to distill this entire discussion down for the clinician who has a full schedule starting tomorrow, what is the definitive takeaway? What is the one clear rule they should take into the clinic?
The rule is this. Recommend low-impact exercise to asymptomatic at-risk adults as a general health strategy. Do not promise proven prevention of symptomatic OA.
Keep it focused on the whole body.
Exactly. If the patient has specific risk factors like obesity, combine this with weight management targeting that critical 10% loss. And if symptoms ever appear, stop preventing and start treating with tailored, intensified interventions.
It is highly nuanced, but it is very clear when you lay it out like that. And it really highlights something that I think gets lost in the rush of daily clinical practice.
What's that?
The why we prescribe something matters just as much as the what we prescribe.
It really does. When we take the time to explain the why, that we are promoting health rather than guaranteeing prevention, we empower the patient. We align their expectations with clinical reality. That is where the real value of the clinician-patient relationship lies.
It transforms the patient from a passive recipient to some imaginary cure into an active participant in their own health journey. They are fully aware of the uncertainties, but they are committed to the best possible path forward.
And that ultimately is the best preventive medicine we have in our arsenal.
You know, this whole conversation leaves me with one final thought to chew on.
Okay.
We have spent this entire time talking about mechanical load, joint physics, and exercise. But if exercise doesn't reliably prevent the structural decay of the cartilage, maybe we're looking at the wrong culprit entirely.
That is the big question keeping researchers up at night right now.
Right, because there was this emerging idea out there that OA might be much more metabolic, almost like a diabetes of the joint, rather than just simple mechanical wear and tear.
It is a massive paradigm shift.
And if that turns out to be true, in 10 years, we might not be prescribing squats or single leg balances for prevention at all. We might be prescribing specific diet changes or targeted metabolic therapies to save the cartilage.
It is a fascinating frontier. We really might look back at this purely mechanical era of OA prevention as just one tiny piece of a much, much larger puzzle.
Something for all of us to think about as we see these patients. Thank you for walking us through it.
My pleasure.
Until next time.